Assalamu alaikum wa rahmatullah. Thank you all for attending this webinar. I'm sure that you are so excited to learn and update your information regarding the COVID situation in Saudi Arabia. We would like first to welcome Dr. Rufaidah AlDabbagh. She's an assistant professor of epidemiology and public health in the Department of Family and Community Medicine in the College of Medicine at King Saud University. And also she's the lead for population health management in the second Central Health Cluster, Ministry of Health.
I'd like to thank you again for preparing this session and making all of the arrangements. Also like to thank Dr. Amr Jamal, our chairman. Thank you, Dr. Amr, for suggesting this activity, and which is actually, it was part of the department's activities that we used to hold before this COVID problem. And I'm really glad that you decided that we should go on with them even within these circumstances that we're living these days. I hope that many other people will really participate in these sessions as well in the coming weeks, inshallah. I know that we have been reading a lot about all of these new updates about COVID. It's really, really difficult to keep track of all of the things that are being published these days. However, I really try to give you just like a very short summary, concise, of all of these, you know, the recent updates that we have. Maybe depending mostly on the Chinese data, because they have the most comprehensive data that has been published until now, and also looking at what the numbers look like in Saudi Arabia, as well as what kind of prevention measures and control measures we have done so far in the country. So at the beginning, I just wanted you to get a feel of what this lecture is going to look like. We're going to talk a little bit about an overview of what COVID-19 is, what we know, and the many things that we do not know, unfortunately, where we are in Saudi Arabia in terms of the number of confirmed cases and what the epidemiology of this disease looks like in our country, what are the population-based preventive and control measures that we have implemented since the beginning and even before the outbreak actually has been detected in our country. What are the different challenges that we have for controlling this disease, and what are the directions we should think about in the future for planning and you know, the right containment measures we need for controlling this disease. Okay, so now, what do we know and what do we not know about this virus? So first of all, we do know what the causative agent is, fortunately. So it was really straightforward. They were able to sample the virus from the respiratory sample from the first case, and that was done in December 30th in China. Once they were able to identify the virus, which turned out to be a beta coronavirus, they knew that they were dealing with something that resembles the SARS-CoV virus, resembles the SARS-like-CoV viruses, and all of the other coronaviruses that have been discovered before, which led them to the conclusion that, well, this is most probably a zoonotic disease that we're dealing with. Why? Because, well, the structure of this virus is very similar to the other SARS-CoV viruses that have been identified and detected in bats and other mammals. However, there are a couple of pieces of the puzzle that they have not been able to tease out until now. So one of these things is that the natural reservoir of this disease is not really clear. Is it really the bats, or is it another kind of mammal, which is called the pangolin? It's found in Southeastern Asia. It's kind of like an armadillo, and you can see the picture of it right here. And it it looks like an armadillo, but I think it eats ants or something. And honestly, this is the first time I've ever heard about this animal in my life. I mean, when we started hearing about this coronavirus outbreak. However, the first person in whom they detected the virus was linked to the marketplace in Wuhan, China, but until now, and after all of the research that has been going on, they cannot link the animal to that first human. So the mode of transmission from the animal to the human is not clear until now. Was it from the bat to the human? Was it from an intermediate host, meaning that the bat transmitted it to the pangolin and then the pangolin transmitted it to the human? That's still not clear. What we do know, however, is that once the disease was detected in that first human, it rapidly was transmitted from person to person. Now, the other piece of the puzzle that hasn't been discovered until now is, what about the pathogenic evolution of this virus? Was this virus originally pathogenic when it was inside the mammal? Was it transmitted as a pathogenic virus from the mammal to the human, or did it mutate inside the first human and then gain its pathogenic potential, and then it was able to be transmitted to other humans? So until now, all of these things remain unclear about this disease. Very important that we do know and learn these things as soon as possible, because it would really help us in containing the virus, containing the animal population, and also looking for different kinds of vaccination options that they can use. So the mode of transmission until now is straightforward. So they have established that it's through respiratory droplets. We do know that the person-to-person transmission is what's going on right now, and it's very fast. We could not link the type of transmission that has occurred between the animal and the people. Some evidence shows us that it can be transmitted through direct contact with infected like utensils, which we call fomites, surfaces, and all that. However, and a lot of speculation has been going on in the past days about airborne transmission. And fortunately, until now, there's no hard evidence about airborne transmission for this virus. I couldn't find anything in the literature, not in WHO information, CDC information, or any other information. So we should still keep a lookout to the new literature talking about the possible airborne transmission. Incubation period was very variable at the beginning of the disease a couple of months ago. However, the more the literature comes out, the more we are quite kneeling towards the incubation period of an average of 5.2 days. It may extend to 12.5 days. Some Chinese literature mentioned that it has, they recorded an incubation period of 24 days, I think. However, the 14-day cap that's been used by the CDC, and which is the basis of the quarantine and self-monitoring that everybody's using as a prevention and control measure, goes more with the average 5.2-day incubation period. The other important thing about this virus is that, or the disease, is that the reproductive number that has been established in the literature is 2.2. What does this mean? Well, this means that on average, every one person who is a case will transmit the infection to 2.2 people who come in contact with him, okay? So this is what has been observed in China. Some other countries reported a higher reproductive period. I think it's very necessary that we look into the reproductive period, reproductive number, in our population, because it really tells us how well the social distancing measure is being implemented and how effective it is in containing the disease. So whenever we implement these social distancing measures, what we're trying to do is we're trying to reduce this reproductive period, reproductive number, in order for the disease to not transmit as quickly as it has been transmitting in other countries. Now, the period of transmissibility, or the period of when the person will be able to transmit the disease to another person, is very variable again. It has been definitely established that people who develop the symptoms can transmit the infection to other people who come in contact with them. People who are asymptomatic may also possibly transmit the infection to other people unknowingly. And in fact, in the Chinese data, about 29% of people or contacts with other people who were infected tested positive without having any symptoms and without even having any signs, not even on CT scan. So we have to be really careful about this issue, because even if we try to trace down all of the people who have come, do have the disease, try to diagnose them as early as we can, tracing down the contacts is very necessary, and keeping those contacts quarantined and staying at home is also necessary to interrupt the transmission of this disease to other people. Now, the symptoms are mostly respiratory tract symptoms, and the most common symptom that has been reported in the literature by far is fever, followed by dry cough, and then comes fatigue and shortness of breath afterwards. Some literature does mention the possibility of gastrointestinal tract symptoms, but these are really, really low and rare. So we're really looking at people who are experiencing upper respiratory tract infection symptoms. The signs, unfortunately, again, there's a lot of conflicting evidence around here. The chest CT scan or X-rays are used when the patients are admitted to the hospital. It doesn't necessarily, or in other words, if you don't find any signs of pneumonia on CT scan or X-ray, it does not rule out the infection. And for that reason, most of the researchers have decided that it should not be used as one of the diagnostic criteria, and they're really not using it. And they're mostly relying on the confirmatory test from reverse transcriptase polymerase chain reaction. Some literature tells us that they have been using the CT scan to monitor progression of the disease. They believe that the chest CT is really sensitive, but of course it's not specific to this new coronavirus that we're dealing with. However, it does not mean that there's no use for it at all in the clinical setting. Severity and prognosis of the disease is really something that we should look out for. So although the data tells us overall that this disease is not as severe as MERS-CoV, it is not as severe as SARS-CoV. And they based that decision on comparing the case fatality rates that we're experiencing right now worldwide to the case fatality rates that have been reported and were linked to MERS-CoV and SARS-CoV. Now, the initial 41 cases that were looked at in China had the most severe disease, actually. And they were a lot of adult people who were over the age of 70. 31% of them required ICU admission, and 15% of them died. However, looking at the larger data that came out from the Chinese reports, suggested that fortunately 81% of the people will only experience mild symptoms, 14% will have some kind of severe symptoms, and 5% of the people will have complicated or fatal progression. Let's go here. Okay, so the epidemiology. So this is a disease that has been seen, as I said before, mostly in the older age population. So the median age of the people who were diagnosed in China were within their 50s. This is the same case that's happening in Europe and in Italy. Surprisingly, in Wuhan, they did not see any cases under the age of 15 years. Overall, in all of the Chinese data, they only detected the disease in 2.4% in children. I mean, the prevalence of the disease was only 2.4%. In terms of gender differences, there aren't significantly observed differences between men and women in terms of who's more at risk. However, most of the literature suggested that the frequency of the disease was a little bit higher among the men. And when we're talking about hospitalization, it appears that most of the people who were prone to hospitalization were those who had existing comorbidities, chronic diseases, people who were immunocompromised, and the mortality was higher among those people who were older than 80 years of age. Now, in terms of testing, I know that a lot of different countries have taken like different preventive measures in terms of testing. The South Koreans just went ahead and they developed this drive-through testing where they tried to test as many people in the population as they could. This is not practiced in the Western countries. In fact, in the United States, it seemed that they're really conservative in terms of when and when not to, perform the testing. And this really also depends on the availability of the test in different countries and the cost of testing and how efficient you are in getting your results really fast. However, the Ministry of Health here came up with really clear guidelines to who really requires testing and who does not. So people who require testing, of course, are healthcare workers who have come in high exposure contact with a case, meaning they probably conducted a certain procedure without wearing their protective mask. The risk for them inhaling a respiratory droplet from a case is very high, and those people are recommended to get tested after 24 hours of exposure to that case. Other people who should be tested are those who are really close contact to a case, living in the same room, sleeping in the same room, patients who were in the same room with other patients who turned out to be cases. All of these people, we should test them, okay? Anybody who is immunocompromised, anybody who has a chronic disease like diabetes, hypertension, renal transplantation, renal failure patients, liver failure patients, should be tested once they come in contact with a case, even if they don't have the symptoms, okay? Now, anybody from the general population who develops the symptoms that are suggestive of COVID-19 and who have risk factor for exposure, meaning they were in contact with a case, they recently returned from a country from travel, they are a healthcare worker, and they have done one of these risky things within 14 days of the symptoms appearing, those people should be tested as well. And any adult patient who has very severe upper respiratory tract or respiratory tract symptoms and tests negative for MERS-CoV and needs hospitalization and needs ICU should also be tested. Now, so where are we right now in terms of the burden in Saudi Arabia? Worldwide, and these data were from yesterday because I could not find the newest data from the World Health Organization situation reports that they update daily. So worldwide, we've reached over 300,000 cases. In the GCC countries, we are 1,224 cases. In Saudi Arabia yesterday, they have told us we have a total of 562 cases. And if we look at this graph right here, you can see that it's showing us the latest number of cases as of yesterday for all of these selected countries. And you can see where Saudi Arabia ranks, which is right here. So the interesting thing about this graph, and I want you guys to really look at it and think about this for a while, is just looking at this graph alone would give us the impression that, well, maybe South Africa, Egypt are doing fine. Iraq, they don't have those many cases. Oh, let's see, Iran. Well, Iran has fewer cases compared to China, Italy, and the US. However, when we compare the fatality rate of these same countries, we can see the disparity between the really well-developed people with a better healthcare system and the people with probably weak healthcare system in terms of case fatality. So, for example, although Iraq only has 233 cases confirmed, we can see that their case fatality rate is greater than what has been reported in Iran and China. South Africa, which only reported 274 cases, has a case fatality rate of 12%. That means that 1 in 8 people of those who will be diagnosed in South Africa with COVID-19 may die. And this is really serious. We really don't want to have a weak system that does not allow us to deal with the cases very quickly and try to avoid as many deaths as we can. Now, the other thing is we can see that Italy, and by the way, Italy has a very well-established healthcare system. They have a very good medical record system. Their health information is integrated with their the national IDs. It's very easy for them to track people down. They have a good surveillance system to begin with. However, their system really crashed because of this, the burden of this growing epidemic. The latest numbers in Saudi Arabia, as of yesterday, tells us that, alhamdulillah, we don't have any deaths until now. The number of recoveries are 19, alhamdulillah. The interesting thing here is that we can see that the proportions of male to female are very different from what has been reported worldwide. We have a slightly higher percentage of women who have the disease. Fortunately, I think as of before yesterday, only 17 children cases were reported. Overall, there were 28,000 reverse transcriptase PCR tests that have been done in the country. So we can just get a rough estimate of what the incidence is of this disease among all of those who were tested by dividing the number of total cases over the number of total tested. Okay, so let's look at the distribution in Saudi Arabia geographically. So if you looked at this map, and I have shared a couple of maps a couple of days ago with the ongoing change in the estimates in the country, you would have noticed that Al-Qasim and Najran were not highlighted yet. However, unfortunately today, we can see that among our 13 regions, 10 regions have had at least one case reported, with the highest cases being reported, of course, in Riyadh region, Makkah region, and in the Eastern region. Now, the epidemic curve. This is what our numbers look like on a daily basis since the beginning of the outbreak. So we can see that the numbers are really increasing. The most number of cases that have been reported was on the 22nd, which was, I think, 119 that day. Let's look at how we compare in our first 30 days to Italy and the US. So the Italians started to have very low cases at the beginning of their outbreak. I think their outbreak started on at the end of January. I think it was January 21st or something like that. So they started with reporting like 1 or 2 cases a day. They had a lot of days where they had no cases actually. And then you can see that on their 19th day, the cases started to surge. They reached their 500 case cap on the 24th day of their outbreak. If we wanted to compare ourselves to them, so we're kind of ahead of them 3 days or 2 days ahead of them, because we reached our 500 cap yesterday. And this is really quite frightening, because although we think we might have things under control right now, inshallah we do. However, we really need to think about what's it going to look like in the next coming weeks. What's going to happen here? Are we going to continue to see the surge of cases? Are we going to be able to contain everybody? Are the social containment measures really being implemented, and are people being compliant with them in the community? Are we able to detect all of the confirmed cases? Can we trace all of the contacts and test those as well? So these are all things that we really have to think about, because it's really going to direct how we should act in the next coming weeks. Okay, so for prevention and control measures, so we have to acknowledge that, alhamdulillah, our government has implemented really good prevention and control measures that exceeded the expectations of everybody, even in a faster way than what has been implemented in European countries and other developed nations. So for that, we really, really should be grateful, alhamdulillah. However, we have to also take care of our personal measures, and because it doesn't make sense for us to اوكي السلام عليكم تسمعوني؟
ايوه دكتور رفيدة نسمع.
Okay. ايوه. So it does not make sense for us to really just rely on the containment measures and not also rely on the personal measures as well. So all of these personal protective measures that we've heard about, hand washing, healthcare worker precautions, everybody should really respect the quarantine measures, try to educate your community and making the right decisions and correct the misconceptions as much as you can. The Ministry of Health has developed a very nice guideline, and I showed you the link right here, that gives you all the information you need to do about precautions, how to deal with the patients, when to do testing, about quarantine measures, and I really recommend that everybody tries to read this document. Regarding the timeline for prevention or population-based measures that have been conducted in the country, and this was really, I have to give credit to my friend Dr. Marwa for preparing this this information. You can see that, alhamdulillah, we have been implementing really strict control measures even before we had the cases. And as you can see in the timeline, the surge that happened a couple of days ago might have probably influence decision to apply the curfew that was applied yesterday. Now, what are the challenges? Well, the first challenge is tracing the contacts. Second challenge is, like we said, how compliant are people with social distancing? We have to keep that in mind. And even when implementing social distancing, we have to think about the different layers of social distancing, because just implementing social distancing alone is not enough. For example, when we close the schools, we have working mothers and fathers who can't take care of their children. Their children might go to their grandparents. Well, a child might be a carrier and might infect the people who are at greatest risk for this disease. So we really have to think about the different layers of social distancing when applying these measures. Another thing is we have a lag between the date of onset of symptoms and the date of diagnosis, and this has been proven in the Chinese literature. As you can see here, by the day they had 500 confirmed cases, there were actually 3,000 people in the population who had symptoms. Something to keep in mind. Another thing to keep in mind, that even with the critical prevention and control measures that we are implementing, we should expect a rise in cases because of the different lag times and because the time it takes us to really identify these cases. So don't be surprised to see a rise in cases in the coming weeks. There's also a challenge in PCR testing, because some literature suggests that there might be a delay in its detection, where it might give us false negative reading a few days into when a person is just early on in the disease. The most important or the most challenging thing I would say for us right now is to think about estimating the hospital capacity that we need in anticipation for the expected rise in cases that we might face in the coming weeks. So from that challenge, I would suggest that we think about preparing or conducting really methodological sound modeling for the future projection of what this epidemic will look like in Saudi Arabia. And these kinds of modeling have been discussed in the literature a lot. They are conducted by infectious disease epidemiologists around the world. They are based on the principal dynamics that that take place between the transformation of a person from susceptible to an infected to a recovered person, and they call it the SIR model. Now, it is quite complicated to look into the coding and to the methodology for these modeling. However, a couple of different institutions around the world have made these apps available for any healthcare professional to use, just for a very simple and quick way of conducting a projection for what the capacity of their hospital will look like in the coming month or so. So this is something that, and I really thank Dr. Suleiman Al-Ghannam if he's hearing me right now, because he was the one who gave me the links to these apps. So this is one that has been developed by epidemiologists at University of Pennsylvania. And it's really user-friendly. All you have to do is just enter your assumptions in their little different boxes, and then it will give you a projection of what the expected number of admissions you will have within a period of whatever period you specify. So based on these assumptions that I have given this app, if we assume that, for example, the medical city has 5 cases right now, if we assume that before we implement our social distancing measures, the doubling time for when, which means the days for until which the cases become doubled, are 4 days. If we assume that social distancing will reduce the contacts by 24%, and so on, based on all of these assumptions, assuming that the market share of the medical city is 20% among the entire population of Riyadh, which is 7 million, for example, and the total cases of Riyadh is 216 right now, then within 50 days, we would project a new admissions of 250 cases just in one day. So I know this is just an assumption, but it really makes us think about, okay, are we really keeping things under control or not? How prepared should we be? Do we have enough capacity? How are we going to allocate the different healthcare facilities in order for them to take their share in accommodating these cases? The other graph just shows us the projection of admitted cases within 45 days. So this just tells us, okay, in 45 days from now, given the assumptions that I gave them, we would expect a little below 1,400 people admitted in one hospital for COVID-19. Inshallah, this projection is not correct. We hope it's not correct. So in summary, I just wanted us to think about, 3 months since the beginning of the epidemic around the world. We're still uncertain about a lot of things. The data from China suggests that mostly a disease of the elderly. The higher risk people are those who have comorbidities. A lot of asymptomatic people may be going around carrying the disease without us knowing. The governmental efforts for prevention and control in Saudi Arabia should be commended, and we should really share this experience with the rest of the world, because this is really something that should be exemplified in other countries. We should really think about right now developing epidemiologic models for projecting the disease in order for us to really know how to accommodate the expected number of cases that we might see in the next coming days. And thank you very much. I think I'm a little over my time, 7 minutes. And I think it's probably a good time to take the questions.
Thank you very much, Dr. Rufaidah, for this nice briefing about the COVID situation. We've received a question. The first question is that, can COVID-19 spread through the fecal-oral route?
Okay, that's a very good question. The literature does suggest that the virus did shed from stool in some of the patients. However, I did not find any literature that actually provides evidence of fecal-oral route spread. But it could be a possibility. I mean, if the virus is being shed in stool, we should keep that as a possibility.
I can take now just a comment from Prof. Ahmed Hirsi. تفضل Prof. Ahmed.
Assalamu alaikum. Thank you very much for the invitation. Shukran, Dr. Rufaidah, for the excellent presentation. Dr. Rufaidah and Dr. Amro asked me to make a comment with respect to our preparedness and business continuity plan. Alhamdulillah, we have started extremely early, at the level of the Saud Medical City or the university, to prepare for the possible and potential outbreak that could happen in our hospital. We prepared. We start our committee meeting prior to the first case in Riyadh, maybe 2 to 3 weeks before the first case in Riyadh, which was on the 2nd of March, as Dr. Rufaidah mentioned. We focus on 3 areas in the preparedness plan. A is the supply chain. Number 2 is the capacity, to create capacity in the hospital. Number 3 is manpower, training, preparedness, as well as making sure that we have a good manpower coverage for the surge in cases if that happens. The second part of the plan was business continuity. We want to make sure that we have a continuous access to care for our patients. and balancing that with the decreasing the flow and the traffic in the medical city. So those are the major things that we planned for. We used when we start to model the potential capacity that we would need in the medical city, the number of cases in Italy was 300 cases per 1 million, and that was maybe at the beginning of the month, first week of March. Today, the number of cases per million in Italy is 1,000. So we based our model in 300 per million. That will give us maybe in Saudi 9,000 cases in the entire kingdom. In Riyadh, that will give us almost 2,500 cases. If we assume in 5% of them would need ICU capacity, plus maybe 5 or 10% will need admission, that means we have to create about 20, and we're going to cover 20% of Riyadh population or share. That means we need to create 28 ICU bed plus maybe 50, 55 beds for admission. Currently, we have 20 beds in the second floor, ICU beds that ready to go and deploy with all the resources needed. We have almost 70 beds in the second, third, fourth floor that could be used for admitted patient. So with respect to capacity creation, alhamdulillah, we are on top of things. We aligned with the Ministry of Health in terms of their strategy in terms of absorbing any extra capacity any extra admission that they might have in their system. Dr. Yasser Laska is helping us with training the residents, fellows on PPEs, and doing a couple of mock cases for transferring patients from and to the emergency room, to the OR or to the ICU, so in PEDS ICU or adult ICU. So I think we're well prepared. In terms of what do I expect, I don't expect that we will reach the number based on our model and projection that the Italian reached, simply because our curve, if you look at our curve, is really different than any other curve. There's no exponential growth in our curve. Italy, they had a very exponential growth. And we started very aggressive measures in decreasing our admission to the hospital when we saw 2 days in a row in an increase in the N. That was on the 12th and the 13th. There was 2 days in a row where the number of cases reported in Saudi were increasing exponentially. But if you look at the rest of the days, the number were erratic. And it's very difficult to model and predict simply because we had a lot of intervention done ahead of time. So I'm not really worried. Although, as Dr. Rufaidah said, I expect to have more cases in the coming few days. I was just in a meeting with the Ministry of Health. They will bring 2,000 students from the US and put them in quarantine for 14 days. So we might have a couple of surge in the number of reported cases, but I don't think we will have a huge increase in the number of cases like other countries who have not intervened early. So that's my comment. Thank you so much, Rufaidah and Amro.
Thank you very much, Professor Alfi.
شكرا جزيلا. الله يسعدكم أبو عمر. If we can continue with questions and answers, Dr. Shada.
Okay. Thank you, Dr. Hersey. Now, there is a question. Is it fetal if a pregnant woman got affected?
That's a very good question. I was actually wondering about that, the impact of this disease on a pregnant woman. And I have to say, I did not come across anything related to pregnancy cases. So that's really something that we should, a person I should go and look into. I really don't have the answer for that right now.
Okay. Are patients who are recovered can be reinfected, according to a published paper in the JAMA network, that they said 4 patients, all patients had 3 repeated PCR tests performed over the next 4 to 5 days after discharge, and then they were all positive.
Mm-hmm. Yes, correct. Yeah, there is some evidence that people can get reinfected. So it's still out there. Not a lot of research has been done about it, but it is a possibility.
Okay. How can we calculate the secondary attack rate for COVID-19?
That is a very good question, and I will have to look into that. Usually the attack rates, actually the attack rates in particular, really have to have the denominator has to be the population at risk, right? And currently, if we want to talk about the population at risk versus a disease, it means that you have to have the number of every single person who got in contact with a case. And that is something that we cannot really calculate or estimate. So probably right now, an accurate estimation of an attack rate is not feasible. However, it's something to look into. I mean, it would be good for us to look into the literature and to see what kind of other methods we can use just to get a proxy estimate of the attack rate.
Okay. The next question is that why do you think the number of cases is low in Africa in relation to malaria?
Oh, that's a very good question. Could there be a relationship with hydrochloroquine is what the person is implying. I do not know. It would be something to look into. However, we should also think about in the developing world that the low number of cases could be also because of their inability to conduct the testing, probably inability to implement good surveillance systems in those parts of the world. So it's really doesn't really reflect the actual number right now. So whatever, if you find the really low numbers in these countries where you know a lot of outbreaks are going on, you should really think about why those numbers are looking the way they do.
Okay. The next question is that do we develop immunity from further infection from corona after recovering from it?
Again, one of the things that have not been well established in the literature. So they really don't know until now if you get immunity, because there was reported cases, as you mentioned before, that have developed reinfection after being infected.
Okay. In order to provide mode of prediction, one of the most important inputs in the is the capacity of each hospital in case you. How can we get it?
Could you repeat the question again?
The question is that in order to, sorry, I missed it. It seems that a lot. Yeah, in order to provide mode of prediction, we need to know the capacity for each hospital in Kingdom Saudi Arabia. How can we get it?
Oh, the capacity of each hospital. Well, there is that data is collected by the Ministry of Health. They do have hospital bed capacity for every single hospital, whether it's private, public, Ministry of Health, Ministry of Defense, and all different ministries. And for KSU Medical City, I think Professor Hirsi could answer that question with the bed capacity in the hospital right now. I really honestly don't know what's our bed capacity.
Okay, can the virus be transmitted from one person to another during incubation period?
Yes, it can.
There is Dr. Khalid Akour with us, and he has got a comment related to the pregnancy.
Assalamu alaikum.
Alaikum salam wa rahmatullahi wa barakatuh.
So thank you so much, Dr. Rufaidah. It was an amazing presentation. So based on the limited literature we have for pregnant ladies, and based on statements and advices that we got from respected bodies in putting guidelines for OB/GYN, pregnant ladies should not be any different from other patients in terms of how do they get the disease and the aggressiveness of the disease and their course of disease and treatment. So they should be treated the same. Also, there are 0 reported cases for vertical transmission from mothers to their babies during pregnancy. And in KSUMC, we developed pathway in collaboration with our colleagues in adult and pediatric ID, in ICU, emergency, ICU, anesthesia, OR. We developed a pathway for those women from the moment they step to emergency until discharge from the hospital. So we are inshallah prepared for those patients.
Thank you very much, Dr. Khalid, for informing us about your preparedness.
Thank you, Dr. Khalid. Jazakumullah khair. If we can, Dr. Shada.
Okay, go back to the questions. There are several questions that arrived asking about the airborne transmission. I think Dr. Rufaidah already covered this during the presentation. The next question is that with the lack of vaccine availability in the near future, how long do we keep mitigation plans?
That is a very good question. Well, I think that that really depends on, relies on more than one thing. First of all, we have to look at the experiences in other countries and the well-established ones in China and Singapore and in North Korea, in South Korea, I mean, and to see what is really the number or the target number that we really want to reach, after which we can say, okay, you know what, this disease is controlled. So one of the definitions of control is that you don't see any new case within 12 to 14 days after the last case that you have diagnosed, okay? And or after the first appearance of a case. I'm sorry, about after if you're talking about case 0 and or whatever number of cases you have right now, you don't want to see any more cases developing after 14 to 12 days from the number of cases we have right now. So we have 0 growth, 0 new cases within a certain period of time. And so that's one of the things, probably one of the criteria. Another thing is using predictive modeling to see what are we going to have in the coming future. However, the uncertainties of this virus are very problematic, because could it turn into some kind of seasonal viral infection? We still really don't know. So I would say that keeping containment measures as long as we can until we really have certainty that we're getting 0 new cases in a certain period of time, then we can really think about when to stop the containment measures.
Okay, is there any ongoing trial for the treatment for COVID-19 in Saudi Arabia? Like what's have been done internationally?
That's a very good question. Unfortunately, I am not involved in the clinical trials, and I don't have any information about them. Do we have anybody here who is aware of that kind of any kind of clinical trial activity going on in Saudi Arabia? I would really appreciate if they can help us in that answer.
Okay, if the patient recover from the COVID-19, can be reinfected again?
I think that question has been asked before, right? And I believe that the literature does tell us that there was reports of people who contracted the disease again, tested positive again after testing, after recovery from the disease.
Okay. Is there any rule for face mask to be used by the community as advised by Chinese experiences?
Well, I cannot say that I am aware of the Chinese experience with face masks. However, I can say that looking into the CDC recommendations and the WHO recommendations and the Ministry of Health recommendations, they really recommend using face masks only by people who are either taking care of somebody who has the disease or by somebody who does have the disease and wants to protect the rest of the people around him from their respiratory droplets. there are a lot of issues with wearing the mask. People have to know how to wear it correctly, on which side. You shouldn't touch the mask, outer part of the mask with your hands, because they will be infected. You have to still have the disinfection precautions in your hands while using it. So I really don't think that there's a clear recommendation for using masks by the general population from our, not from the Ministry of Health, not from the CDC, and not from the WHO.
If you allow me to comment, there are also two issues. That the mask itself could be a source of infection, especially if they don't know how to use it, and also how to get out of it correctly. And secondly, that will be depletion of resources. If we use masks currently for unneeded causes, especially in the community, when we really need it, لا قدر الله, there will be resources loss. There is دكتورة حفصة. تفضلي دكتورة حفصة.
Hello, assalamu alaikum. Thank you, Rufaidah. Congratulations. Nice presentation, very nicely prepared, and the information is very well needed by the communities and people around us. I would just suggest that if you can shed light on the herd immunity concept, maybe that can help answering the question that people are asking of reinfection, because this is going on in the international media as well, and there are lots of speculation about the concept of herd immunity now being playing its part in the whole pandemic. So maybe, and I think also, I mean, all this literature review and all reading and speculation, I also think that now, or maybe in the near future, we may be, even in Saudi Arabia and also many countries that have now started to report a decline in the number of cases that are coming up, maybe they're developing some sort of herd immunity. And because if we go on testing every person, I mean, we are getting so much surprise that most of the people are positive, although they are not showing signs and symptoms. Hence, that reflects that this virus is there in everybody. Maybe it may be there in everybody. And once you get tested, you confirm to that. However, not all of them are showing signs and symptoms. And this can be due to the fact that they have developed by now some sort of immunity towards this, because they have been exposed to the virus in some way or the other. So maybe that can answer our question of reinfection. Maybe we will not get reinfected once you are having the virus, once you are carrying the virus. That would be enough for you to have some sort of protection. So we can see the same case in measles, in polio. Once you introduce the vaccine, or once you sensitize the person towards a certain bacteria, plus you are producing immunity. And if you see in measles case, what do we do in measles? When we vaccine, or when there is an outbreak, we give a vaccine to some people, and it gives automatic protection to others. Maybe this would be working later on sooner in this case as well.
Thank you. Thank you, Dr. Hassan.
Mm-hmm. Mm-hmm. Yeah, thank you very much, Dr. Hafsa. Yes, I mean, technically from a epidemiological point of view, herd immunity is necessary, a necessary thing to think about in the whole model of transmission from susceptible to infected to recovered. And however, I have to be honest and tell you that I really did not look into the literature talking about, what are the options of herd immunity, maybe because we still don't have vaccine yet. And not a lot of people are thinking about how, what are not optimistic about herd immunity being, one of the plausible ways of washing this virus out. Severity of the virus infection is also something probably that's really making people panic. It's really hard to say. But from a technical point of view, really the definition of reaching herd immunity kind of tells us from an epidemiological point of view that the reproductive number is really close to zero. So that's what we really want to reach. So we want to reach the point where the reproductive number or the number of people who get infected when in contact with one case becomes zero. Dr. Amr, you wanted to say something?
No, thank you. I could not add anymore. We exceeded the time, but Dr. Rashada, if you can take one or two questions more, it's up to you.
Let me just look quickly at those questions. Why the prevalence is low in children? How we could explain this?
I really don't know. That's very an interesting conundrum. It's been exhibited in all different kinds of literature. Some researchers have tried to explain it by saying, well, maybe children are just asymptomatic carriers. Maybe the symptoms only appear in adults. So they really don't know, because a lot of children have been tested positive, but they were asymptomatic. So it really looks like this disease is something that targets the adults in terms of more severe disease, more symptomatic disease. We could have possible children who are carriers who are asymptomatic. We don't know. In Saudi Arabia, it was reported that 17 children have contracted the disease. However, all of the literature suggests that the children, the type of disease that is experienced in children is really just mild respiratory symptoms, with very little children who needed actual hospitalization. If not, nearly almost nothing. Nobody, needed hospitalization, or it's a really small fraction who needed hospitalization.
Oh, okay, the last question is that is it more aggressive in smokers compared to non-smoker?
I do not know, but if we really want to think about the impact of any kind of respiratory disease on a smoker, so we would expect it to be like a more severe, like any kind of other respiratory disease. However, I did not see, I don't think they're really focusing right now on, those little individual risk factors in the literature. Unfortunately, although we should expect some more information talking about personal characteristic risk factors, lifestyle, behavioral risk factors, and how they impact this disease.
Okay, thank you very much. Thank you all for attending this webinar. Hopefully you get updated your information regarding COVID, and that's it.
Thank you very much, Dr. Rashada. Thank you, Dr. Amr, Dr. Prof. Hirsi, and everybody who participated. I'm very happy that we were able to have this nice discussion, and I really look forward to the activity being continued in the next coming months. Probably we can make it like a weekly activity, different speakers talking about different topics related to COVID 2019, and inshallah we just hope that we can spread knowledge and share it with each other.
Inshallah. Thank you.
Thank you all.
Thank you very much.
For the good attendance. MashaAllah, the attendees exceeded 135. It's much more than the face-to-face sessions. Maybe we'll continue even after the COVID pandemic. Inshallah, to continue to have both hybrid, the face-to-face, and also the through Zoom or any other modalities for the distance webinars. Thank you all. جزاكم الله خير. سبحانك اللهم وبحمدك أشهد أن لا إله إلا أنت أستغفرك وأتوب إليك.
Thank you very much. مع السلامة.